So we're going to talk about preconception. So just to clarify or say what we all know, pregnancy and IBD can be its own 1 hour plus talk. So we're going to go through some of the biggest take home points, but we're not going to get to everything today. So we're going to talk about preconception as well as pregnancy and the main things that I want you to think about as you are talking to your patients when they're planning families, as well as during the pregnancy process. So preconception. There is really nothing more important than disease control before pregnancy because that predicts disease control during pregnancy. So we know that active disease is associated with reduced fertility for a variety of different reasons: pelvic inflammation, poor nutrition, depression, libido, dyspareunia, as well as an increased risk of miscarriage. And then active disease at conception is associated with relapse during pregnancy. So I often say to patients, if you go into pregnancy in a deep remission, you're more likely to stay in remission. If you go in while you're flaring, you're more likely to flare. We know that active disease is associated with adverse pregnancy outcomes, including preterm birth, stillbirth, low birth weight, preeclampsia, preterm premature rupture of membranes, and medically indicated preterm delivery. Some of these are actually related to steroid use that can stem from active disease, and that these risks are greatly reduced when disease is controlled. So if I'm going to emphasize one thing during a preconception visit, is that we want somebody to be in a very deep remission. So a steroid-free deep remission, so symptoms and scope, at least 3 months prior to pregnancy. So how do I personally address preconception disease activity? So first I decide, is somebody in clinical remission? If no, and we have objective data that their symptoms are not due to something like IBS, they need a medication adjustment or a surgical referral before they consider pregnancy. If yes, then I go back and say, do they have any objective evidence of disease control in the last 6 to 12 months while on their current regimen and they haven't flared in the middle? So do they have imaging? Do they have a capsule? Do they have a scope? If yes, I give them the green light. If no, then I look back at their remission history. Do we ever have a confirmation of deep remission on their regimen? If not, we're going to restage them. We want to do a scope. We want to get labs. I often try to get a calprotectin and an intestinal ultrasound as a baseline. Intestinal ultrasound, obviously not available everywhere, but at least a calprotectin. This is the only lab that's not going to change with a normal pregnancy. So we really want to know what this is when we start out. If we see deep remission, they can start. If they do have prior confirmation of deep remission on this regimen, they don't have recent endoscopic data or imaging, but they really haven't had any change in their symptoms or medicine, then I do a less intensive approach like a set of labs, calprotectin and ultrasound if available, and then I give them the green light. And if any of these things show active disease, they need an adjustment before we think about pregnancy. Really importantly, because we get a lot of patients referred to us as a specialty center whose primary doctors have not felt comfortable with them being on IBD medications during pregnancy. And so they stop them, either in anticipation of pregnancy or when a patient becomes pregnant. And the most important thing I can say is that active disease and not medication is associated with adverse pregnancy outcomes. We want the steroid-free deep remission at least 3 months prior to conception. So do not stop IBD medicines. Very few important exceptions. One is methotrexate, which we know is teratogenic. That needs to be stopped 3 to 6 months before trying. Ozanimod needs to be stopped at least 3 months before trying. It can affect blood vessel development in the fetus. It has a long half-life, at least 12 weeks, so you have to stop it earlier. Tofacitinib and upadacitinib, we don't have a ton of data in humans. The data we have in animals suggests that there are some problems with fetal, really scapula development. And so we recommend avoiding it at least in the first trimester or using it with a lot of caution. And we'll talk a little bit more about that later. But if somebody is doing well on one of these medicines, we want to transition them to something else that's safe. And then thiopurines, if somebody's on thiopurine monotherapy or on combo therapy and really needs that thiopurine to stay well, keep it on. If they're doing great on combo and you've been looking for a time to peel it off, then it's a good idea to peel it off because there are some data that suggests combo therapy can cause an increased risk of infection in the first year of a baby's life. I always measure drug levels before pregnancy, and then I measure them throughout to help time pregnancy medication dosing. Very briefly, we have a lot of data at this point on the safety of biologics during pregnancy. We have data on TNFs, vedolizumab, and ustekinumab. This is data from a systemic review and meta-analysis, but there have been several studies also published from the Piano Registry, all basically demonstrating that there are no increased risks of any of these adverse pregnancy outcomes compared to the general population in patients who are on biologic therapy. So what do I do when I see a patient who's going to become pregnant? First, I think about who are all the people that I need to be involved to make sure that they get the best possible care. Almost all of our IBD patients, aside from those like super well-controlled, very mild UC patients on mesalamine who have never had a flare, or somebody who's on Remicade for the past 15 years and is doing perfectly well in the last 10 scopes, should have at least a consultation from a high-risk obstetrician or a maternal fetal medicine specialist. These are people who have complex chronic disease at baseline and are higher risk pregnancy just based on their IBD alone. They're on medications that a lot of general obstetricians are not comfortable with, and they may have a surgical history that needs to be considered. We also want to involve colorectal surgery, particularly in patients with any prior surgical history or perianal disease. And in patients who are going to have C-sections, for example, we want a colorectal surgeon to be present if they have a surgical history, since there may be adhesive disease or other things that a colorectal surgeon should really be involved to help with. And then we also want to make sure that nutrition is optimized with caloric intake and vitamin levels before pregnancy and during pregnancy. So big takeaways: steroid-free deep remission for greater than or equal to 3 months before pregnancy, objectively confirming deep remission in some capacity before conception, educate on the importance of continuing medicines before and during pregnancy, noting that adverse outcomes are associated with active disease, and there have not been really any adverse outcomes in babies born to moms on biologics. If you need to make a change, reconfirm remission on the new regimen before pregnancy, and consider a multidisciplinary approach whenever possible. So a few minutes quickly on pregnancy. Flares, the big fraying red box, and something everyone's afraid of during pregnancy. First of all, just to note, calprotectin is your most reliable marker. Only one of our labs that is not affected by normal pregnancy. I tend to trend this every trimester because it will rise before a patient develops clinical symptoms. And I will also check it with a change in symptoms because pregnancy has a lot of related GI symptoms that are not inflammatory. And so you really want to be able to differentiate. Always be checking for infection with C. diff and GI-PCR. You can check labs, but remember that ESR, CRP, and white count will go up in a normal pregnancy, and hemoglobin and albumin will go down in a normal pregnancy. So just because you see these doesn't mean that a patient is flaring. Imaging, MRI and CT are essentially equivalent. We don't want gadolinium in the first trimester. A single CT has really minimal cumulative radiation risk, so if you need to do it, you can do it. The best tool that we have is intestinal ultrasound. That's not available at a lot of places, but if you have it, it's amazing because I use it to monitor every trimester, and then I use it if patients are having sort of changes in symptoms, or if I've started any kind of medication, I'll check a response, and you can see really quickly changes in bowel wall thickness and blood flow. Medications. Avoid starting the things we talked about, not continuing in pregnancy, but everything else is fair game. If you need steroids, you can use them, but you should have a plan to transition to something else. They're not a long-term plan. Rectal therapy is your best friend. A lot of the symptoms in pregnancy are related to active distal inflammation. So patients do really, really well, especially with steroid foams, because they're easier to hold in, but Rawasa, Canasa are also great. You can start a new biologic really anytime if you need to. And then there's sort of a question in terms of management style about starting upadacitinib after the first trimester in a patient who really needs it because organogenesis has been complete. Endoscopy, if you need it, do it. You can do it for strong indications. So if you need to determine how active someone's disease is or whether you're going to change your medical management based on the scope. Flex SIGs are great because you don't have to prep someone and they can be done ungated and you can do it in any trimester. But if you need a full colonoscopy, it's fine to do it. Sedation is really okay anytime, but remember that later in pregnancy, somebody's going to be more likely to require intubation, and that's important just because of their body habitus and growing uterus. And you also have to make sure you're paying attention to positioning because you don't want to squash their IVC. And then lastly, if somebody needs surgery, they should get surgery. So acute refractory colitis, a perforation, an abscess, someone with severe hemorrhage, or a bowel obstruction that's not resolving with conservative management. There's always talk about the second trimester being the sweetest spot because you're outside of the window of organogenesis and placentation, and you're before the time when you're likely to cause someone to go into premature labor. But if you need to do a surgery at any time for the safety of mom, you can do it. So just like 2 minutes on medications, low risk medicines, all of our mesalamines, sulfasalazine and valsalide. Sulfasalazine, remember you have to give 2 milligrams folate, budesonide, basically all of our biologics, thiopurine monotherapy, and short-term antibiotics. Moderate risk, prednisone, remember this is for flares only and not for maintenance and can cause a lot of different risks in mom, as well as a possible risk of orofacial cleft with exposure in the first trimester. Combo therapy, as I mentioned, you can keep it if you need it, but if somebody's in deep remission, consider stopping the thiopurine. And also remember that allopurinol is possibly embryotoxic, so to use that with caution. And then avoid JAK inhibitors, ozanimod, and methotrexate. just very important to reassure mom, almost all of our biologics, with the exception of certolizumab, which never crosses the placenta, do cross the placenta, but they require the formation of a specific receptor called the FC receptor. This isn't present until late in the second trimester, and most biologics don't cross till the third. So I always reassure mom, the baby is going to be fully developed and just growing the time he or she sees that biologic. The last dose of biologics, time them so the patient's due at delivery. So if they're on every 8-week Remicade, give it to them at 32 weeks. Remember that you want the lowest level of drug in circulation at the time of delivery because it's going to cross the cord blood. You can adjust your timing based on levels. Some data that Remicade levels go up in the third trimester. So if you need to space it out a week or two, you probably can. And last dose of thiopurine should be around week 34 to 36 because of the long half-life. And lastly, like if you need to continue someone's medication so that they don't flare, don't say like, oh, it's too close to delivery, we should risk the flare, just continue it through. I'm going to skip this for the sake of time. Mode of delivery, only absolute indication to vaginal delivery is active perianal disease. Think about if somebody has a history of rectovaginal fistula, a history of perianal disease involving the sphincter or prior perineal surgery, because you want to make sure you're protecting the integrity of that sphincter at all costs. And a high degree tear could then end up causing somebody to be incontinent. And then history of pouches, we often recommend patients get a C-section, but it's not an absolute must. That's a discussion with the MFM. Active UC if you're concerned that someone's going to need an IPAA in the future, just because you want to protect the sphincter. And then people who have different contraindications for pushing, like orthopedic issues, or patients who are going to have a lot of babies, like certain patients of ours who want to have 10 babies. Those are patients who should not be going to C-section necessarily, even if they have certain indications, because repeated C-sections are associated with increased risks. And lastly, involve the colorectal surgeon if you're planning to do a C-section in someone with a surgical history. So how should you counsel your patients? Emphasize the need for disease control before and during pregnancy, review medication safety, confirm a steroid-free deep remission prior to pregnancy, continue your medications unless they're one of the contraindicated ones, in which case make a safe switch and then confirm remission again before you let someone be, or you advise someone that it is safe to become pregnant. Multidisciplinary care is available if you can do it. And if you need help, refer to us. We have an IBD pregnancy clinic that's run by myself and Marla Dubinsky with the co-management of a high-risk OB, Joe Birkin. We are happy to see your patients at any time for a consultation, and we would love to help you.